Good day. We'll start, even though apparently they're a bit late in the other workshops. So I'll introduce the next speaker, Katri Raymond. Katri is a trained occupational therapist. She's currently pursuing her doctoral studies in healthcare research at Sherbrooke University inside the GRIMN, the Interdisciplinary Research Group on Neuromuscular disease. She didn't want me to read her whole bio, it's very long, but I just want to know that she's been doing research for a long time. So there, thanks. Very long, well, a few years, but still. Well, good day all. Thanks for being here for this last presentation of the day. It's a lot. So, of course, we're a bit more tired, so I'll try to make it more jovial, so to speak, to allow you to be have a bit more interaction. My title is rather ambitious. Learning in 60 seconds the specificities of OT interventions for adults with myotonic dystrophy. It's ambitious, and I guarantee I won't be able to do it in 60 seconds. So today I'll really deal with 3 distinct sections. I'll talk about a simplified practice guide that we've developed with the collaboration of wonderful occupational therapists. And how did we develop such a guide of practice in occupational therapy, which is simplified and easy to understand? And I'll also talk about the recommendations of the guide, so you'll see what kind of recommendations were put forth. And if you appreciate, maybe you'll be able to go read this guide, which is free online on the internet at various locations. So I simplified the practice guide. Well, everybody knows MD1, everybody knows there are many characteristics which can lead to restrictions to social participation. So occupational therapists, or OTs, will need to intervene in key moments during the disease's progression with people who have MD1. And we'll find OTs in first line, second line, and third line who will make interventions. Nevertheless, compared to persons in second and third line of intervention, OTs of frontline OTs will more rarely meet people with this disease, and perhaps they'll see 1 or 2 in their entire practice. So maybe they will have more difficulties, or maybe they'll be less well-equipped to do the case management for such a disease and to face the various specificities which could occur. This is why the frontline stakeholders need a practical guide, but you can't find such guides easily. It's difficult to adopt a practice that's evidence-based, especially in frontline, but also for all the other lines, obviously, because, of course, we don't have a lot of time to get information on a disease which is quite specific. There are also few available evidence-based data, and the data we could find might have low quality. For example, you could have access to descriptive studies, exploratory studies, but it's hard to find studies of randomized clinical trials that give a strong value to an intervention. So what you end up with is an absence of practical guide, or when you do have one, it's generally very theoretical, it's long, it's dense, and evidence-based, it's hard to find in such a thick a guide to find out how do you act with your patient, the only one in your caseload, because when you have a very long waiting list and you see one client, do you really have time to read the whole practice guide? That's very long. Luckily, in our case, there's a long practice guide which was developed for the second and third line occupational therapists. It's quite recent. It came out in 2015. It's a group of students from Sherbrooke University. They were studying in their master's degree. They did this practice guide in collaboration with the GRIMN, and this guide was developed based on evidence-based, and since there were very few of them, it was also developed thanks to the OTs that are experts in disease, who know how to intervene and who really had empirical data to supply for this guide to allow it to be well-based, well-founded on data which are factual but very specific to help persons who have this disease. So this guide, unfortunately, is not adapted to frontline practice. So it's important to be able to simplify it. How did we want to simplify it? Well, we wanted to adapt it to the local context because we know this allows us to improve evidence-based practice. When you have a practice guide that looks like your professional practice, well, you have a tendency to read it and apply it far more easily than if it's far from our context and if it's completely out of our field. And also, a practice guide has to be a user-friendly tool, easy to use, it's not long to consult, because we don't have a lot of time in a clinic to do so. So these were the challenges we wanted to try to deal with to create a simplified guide of practice. How did we develop it? Well, we started by throwing the idea out in November, December 2015 to the order of OTs, where we asked for funding for the program transfer, the knowledge transfer program, and we received $4,500 from the Order of Occupational Therapists to implement this project. And the project was really to simplify a pre-existing guide using the Rare Knowledge Extraction Guide, which is a model for the development of practice guide that was made and adapted to neuromuscular diseases. So to really represent the neuromuscular diseases, because it's not true that a practice guide for cancer will be developed in the same way as one for neuromuscular diseases. So we did this in 5 phases. Phase 1 was to figure out, well, what does an OT do in the front line? What are his professional activities? What is his field of expertise? So we went to read in the benchmarks and the reference guides, and we went to consult frontline OTs, all diagnosis confounded, to know, did they find that the professional activities that we had identified were representative of what they did, and to adjust it in such a way. Then we did phase 2, which was to go take the long practice guide, extract the data that were relevant to the professional activities of the frontline OTs. We did this with 2 OTs, Cynthia Gagnon and myself, and we did it separately to arrive at a consensus on the information that should be conserved, that were most useful for professional activities of frontline OTs. And if needs be, there were no dissensions, so everything was done consensually. We didn't need this third party. After that, phase 3, we came up with a preliminary version, but we wanted to consult expert occupational therapists. So we went to validate the information we had pulled out of the long guide, the long version, by doing a focus group of 6 expert OTs. And we really wanted them to put forth their expertise to improve this guide, to pull out what was unimportant, to really represent the current state of the practice and define what are the specificities of OT practice for a person with DM1 and frontline. So people who work with them. Now, phase 4 was to go back and see frontline OTs with a focus group to validate the guide that had been completed and refined by expert OTs to see if this satisfied what they did in their practice. So the experts said, well, dysphagia, it's something which is very important, that needs to be screened, we need to intervene. Now, frontline OT said, yes, screening good, but intervention, it's outside our field of competence. We can make recommendations that are general, but apart from that, we'd rather just refer to specialized services who will be far more equipped to take charge of the person. So this modified the guide, an example of modification. And then we needed to produce a pre-final version, get it validated by all the OTs who had participated in the project, and create a final version which was presented to the convention of the Association of Canadian Occupational Therapists in Charlottetown. Eventually, we would like to translate into English to allow the whole Canadian OT community to leverage this guide, and eventually perhaps for the rest of the world for the practices that are comparable to ours in North America. So that's where we're at. During the whole process, of course, it would not have been possible if we did not have an access to an exceptional knowledge broker, Mrs. Annie Plourde, who was in contact with the OTs and set up the guide, who was able to really gather all these people around the same table so that we'd be able to talk. And, of course, the order of OTs who funded the project. So, what's the result? We went from a guide of 80 8 pages with a continuous page that was dense based on the theoretical model that gave general recommendations for a second to a simplified 10-page guide with checklists, which is easier to read based on the Canadian occupational performance model, the MCRO in French, more adapted to the frontline OTs, and then we had recommendations and interventions and assessments that were more targeted for the frontline OTs. So it was more quote-unquote representative of the practice. So we went from this to this here. Maybe you've seen the guide. It was at the front. There are no longer any copies left, but there are many business cards that you can take where there's a hyperlink to have access to this guide. It's free on Savoir UDS or Muscular Dystrophy Canada. The guide is also available. So with no further ado, the guide was divided into 4 main sections. Something facts to know, what the guide is for and how to use it. Part 2, description of the disease, more brief description, which gives the main symptoms that to keep in mind. That could be issues in your occupational therapy practice. And then we have a section which is really on the challenges of case management. Because there are some particularities which will have an impact on practice in OT. And I'll come back to this point in a few moments. So then we based the model on the MCRO by looking at the assessments, intervention, and a bit of contextualization to give clear ideas. And we really did it based on the assessment order that we generally have in OT, the environment, the frontline OT. The first thing they do when you arrive in the home, they count the number of steps, they look at their ramps, if they're adapted access. Then we look at personal care, productivity, and leisure. Now, for case management challenges, one of the first information we wanted to share is the causes of mortality. Because even though the OT doesn't necessarily act on the cause of mortality, we have to keep them in mind because they can have an impact on the interventions. Know that the first cause of mortality is respiratory infections, probably related to pneumonia, and with the presence of silent aspirations for dysphagia. So we'll know that it's more important to screen dysphagia and also perhaps to look at oral hygiene. The less you have dental plaques in the mouth, the less you have cavities, well, less chances that you'll have infections if you bring a piece of food which is infected by our oral bacteria into the lungs. So we slightly reduce a risk factor for respiratory infection. The second cause of mortality are cardiac complications. We've seen it perhaps earlier on where we know that cardiac complications really require an annual follow-up medically, but it can allow the occupational therapist to make sure that this follow-up was done, and it can also be seen as a counterindication to do exercise or to do certain activities with us. So we have to consider this. We always had a small section on physical appearance, just simply to allow the OT to normalize, if needs be, if the person feels perhaps different. So then, we have a section on apathy, because we know more and more that person can be hit with apathy. Dr. Benjamin Gadet spoke about it in a previous conference, and he's the one that put forth this fact. But 40% could be have problems with apathy. It could be confounded with a lack of motivation, kind of an indifference faced with the treatment, and they don't want to be involved in the treatment. And some person could even talk about laziness. And I would say that you have to be careful, because we could believe that it's like depression, but it's not necessarily depression. People will have difficulty initiating activity, getting involved, but they won't have a loss of pleasure. So once they're in activity, they will have as much pleasure as anybody else. So we really have to distinguish between both depression and DM1. And it's a challenge for intervention because people will be less proactive, less committed. And it could give you an impression of lack of collaboration in the care. And it happens that the frontline persons will kind of close the file because they have a lot of collaboration. So the second and third line interveners call back and say, the person needs care, but the frontline person says, might have closed the file too quickly. And that's something that was shared to me by nurses of the Neuromuscular disease clinic. So it happens even at the Saguenay Lac-Saint-Jean, where people should be more aware of the characteristics of a disease. And also one of the relevant information that came out following this is people have interests. And when you target these interests, you can really bring back people to be a bit more active in their care and more involved. So if you target a specific interest, they can help them become more functional that way. Security of patient, risk of fall, that's really a key point that was mentioned. And we wanted OTs to have specific attention to this because people have a tendency to minimize these risks, and people are afraid of leaving the house and they isolate themselves socially because of this fear of falling. And there's a triad also, perhaps related to mental health, personality, difficulties of social integration. So we tried to make the OTs aware of this, and we provided to them intervention solutions. For example, privileging, be vigilant for risks of abuse, try to teach techniques for stress management that are simplified in such a way. Then with, of course, fatigue, drowsiness, which can kind of lead to, they get to bed late, they get up late, perhaps, increase telephone contacts, appointments at the end of the day, and perhaps you'll get more collaboration with the patient that way. And we also know that DM1 gives you the parent aging, early aging, so you can help a frontline OT by acting as if the person had an aging phenomenon to orient their interventions. And if we dig into the recommendations for the assessment, I think most of you know this already, but this allows us to go target specificities for type 1 myotonic dystrophy. First of all, for the assessment of the environment, it's really prevention of falls, which is central, and we suggested the IRIDA matrix. It allows you to cover all the aspects of the environment, so it can really help the structure of the practice, but it's already fairly well implemented, but not everywhere. Afterward, the interventions we gave several types of adaptations that are functional and that are used by persons who have this. And we reminded them the home adaptation programs and material help programs that are available. Then in the personal care, we really went into the assessment of certain activities, which are issues, amongst other medication management, hygiene, dysphagia, and also with specificities of disease related with symptoms. So muscle weakness, drowsiness, mixtional emergencies, which forces the person to go quickly to the bathroom and have a higher risk of falling. And we give them more factual information. So 70% of persons who have difficulties in activities of daily life. These were data that were taken on a transversal study where the cohort were rather young. So in my opinion, these are data that we have to take with a grain of salt because there's more difficulty than that in the activities of daily life, and the more the disease progresses, the more you'll see them. We also talk about the characteristic, the person will have a specific prehension or grip, and this will hurt with the activities of daily life. And we give intervention solutions for myotonic, occupational routine, and the references you can do if needs be. And for the productivity, it was divided in several sections. We have a person when they move inside, we know it's more difficult. The key point is to really do a multifactorial assessment as we would do with an elderly clientele, because we know that there's not just the disease, but also an interaction with the environment, which will lead to risks of falls at home. And for example, transportation of objects would really disrupt the gait, where perhaps it would not do so for another disease, and which will lead to a higher risk of falls. Also, other interventions are suggested, amongst others, for the protection of urinary leaks and their physiotherapy references. I can even add here perhaps conventional physiotherapy, but also You can help peri-renal for mictional emergencies, and you can also help with community travel. For example, screening, because people will be very uneasy to talk about difficulty in driving because they'll be afraid of losing their driver's license. So you have to consider this. But also, once you're in the community, well, sometimes people will try to use more and more wheelchairs, so to make sure that the person will not be isolated socially, so that we act in the community, and this depends on the first line also. In the interventions, it's fairly usual. Parking, special parking, adapted transportation, refunding programs, which can be available, and mobility programs, so quadriporter or electric wheelchairs can help people to be socially active and continue to move around, especially in the summertime. In the winter, it's much harder. So we spoke also of the parental role. We added this. It's something that was not available in the long guide because there are challenges for a person with this disease, and the frontline interveners have to be aware of this, and we refer them to Parent Plus Clinic, which is a resource available for all of the province of Quebec, hosted by the Lucie Bruno Center, and which is for parents who have physical handicapped children, when they have babies between 0 and less than 2 years of age. So we have the information that's relevant to know how to have access to this clinic. It was a resource that myself I didn't even know. So I was very happy to be able to add this in the guide. And we conclude with the leisure, where you'll really go and see if there are leisure in their occupations, and also a specific moment where we can go see are there depressive symptoms, anxiety, because yes, it can occur even with a disease that we could believe that apathy could lead to depression. No, there could also be a depression. And we can suggest respite services. And there's also a small section on physical activity where we say it's not damageable for the muscular system, but we really have to make sure that the contraindications are considered, and to make the person sure that really if they're fatigued, or to stop if they're winded, because it could be difficult for them. And we suggest once again to use a person's interest to improve collaboration and to work around apathy, and this can really help the occupational therapist to have a better collaboration and to better intervene with these persons. So that was the Simplified Practice Guide. It's available on Savoir UDS, Muscular Dystrophy Canada, and there were copies at the front, but now they're all gone. But you still have the small cards which allow you to have access to know the link to go see where it is on Savoir UDS. So thank you to the Order of Occupational Therapy, but especially to all the OTs who contributed to this guide, because without them, this guide would have been far less adapted to frontline practices. And we have here OTs that participated in this guide, so I wanted to thank them in person. So thank you all. And you can even scan this QR code with your cell phone if you want to have direct access to UDS to obtain the guide. Thank you. If there are no questions, I'd invite you to consult the guide. And to thank the OTs, if you know them, who participate in this project. Thank you very much. Have an excellent evening, because I think there's one conference, a conclusion conference, but then you'll be able to enjoy this wonderful city, but with a bit of bad weather.